So today we'll discuss about our first neurodegenerative disorder, that is Alzheimer's disease. Now, in Alzheimer's disease, there is an amyloid precursor protein. Alright, this amyloid precursor protein is present inside the neuronal cells, in the cell membrane of the neuronal cells to be specific. What happens to these amyloid precursor protein is that they are acted upon by secretase enzymes inside the in Alzheimer's disease. The secretase enzymes are of two types, the beta secretase and the alpha secretase, and they produce their respective products, being the alpha secretase product and the beta secretase product. The problem arises when beta secretase protein is product is further degraded by gamma secretase to produce A beta 42 and A beta 40. Out of these, A beta 40 is non-toxic while A beta 42 is toxic. Right, it is an amyloidogenic beta plated sheet protein. So A beta 42 molecule is neurotoxic, resistant to degeneration, and it aggregates rapidly. So as it aggregates, it is seen as an NFT, neurofibrillary tangles, inside the cell, and it correlates with the severity of the disease, meaning that if neuron NFTs increase, the severity of the disease shall increase. So it denotes the severity. Normally inside the cell there are tau proteins. Inside the neuronal cells there are tau proteins which maintain and stabilize the microtubules inside it. So these NFTs cause these tau proteins phosphorylation, thus leading to destabilization of the microtubules and at the end of the day leading to neurodegeneration. So A beta 42 has these implications inside a neuronal cell. On the other hand, in cerebral vessels, now whenever they cause any pathology of the cerebral vessels, that is known as cerebral amyloid angiopathy. Cerebral amyloid angiopathy. So they affect the cortex of the affected patient, leading to cortical dementia. The cerebral vessels can also lead to senile neuritic plaques. Uh, senile neuritic plaques can be seen inside these cerebral vessels. So these are extracellular and correlate with age. So what we have done till now, uh, we've seen that in Alzheimer's disease, there is Alzheimer's amyloid precursor protein. Yeah, amyloid precursor protein, which is acted upon by various secretase enzymes. So it could be the alpha secretase or could be the beta secretase, which alpha secretase produces alpha secretase product and beta secretase produces beta secretase product, acted upon by gamma secretase, which leads to A beta 42, which is toxic, could cause amyloidogenic changes. Moving on to A beta 42 molecule. A beta 42 molecule is neurotoxic. It is resistant to degeneration, aggregates rapidly. A beta 42 is neurotoxic, resistant to degeneration, aggregate rapidly. Neurotoxic, resistant to degeneration and aggregates rapidly. A beta 42 and neurofibrillary tangles, seen as neurofibrillary tangles inside the cell, inside the neuronal cells. Thus, protein intracellular correlates with the severity of the disease. Normal neuronal cells have tau proteins which maintain the microtubules inside of it, their stability. If tau proteins, then NFTs cause phosphorylation of the tau proteins, thus causing destabilization of the NFTs, leading to neurodegeneration. Now, A beta 42 causes these changes inside the neuronal cells. Well, it's inside the cerebral vessels. It would cause cerebral angiopathy. I believe it is cerebral amyloid angiopathy. Cerebral amyloid angiopathy. CAA. The only cortex affected. So cerebral vessels, in these only cortex is affected. Could lead to cortical dementia. Senile neuritic plaques can be seen. These are extracellular, by the way, which correlates with the age of the patient. Whereas neurofibrillary tangles were correlating with the severity of the disease, here they're correlating with the age of the patient. These are extracellular senile neuritic plaques. Although senile in their name denotes that they might correlate with age. Senile neuritic plaques. Let's revise this one because I am forgetting this again and again. A beta 42 could cause cerebral vessels, and A beta 42 cerebral vessels of the the pathology of the cerebral vessels by the A beta 42 protein would lead to cerebral amyloid angiopathy, known as cerebral amyloid angiopathy. The cortical dementia and senile neuritic plaques shall be seen. Cerebral vessels A beta 42 pathology lead to is known as cerebral amyloid angiopathy. Yeah, this time I got it correct. And it affects only the cortex, leading to cortical dementia, cerebral vessels, senile neuritic plaques. These are extracellular, correlate with age. Now let's come to the genetics of Alzheimer's. Uh, Whatever I remember about it is the chromosomal mutations. There are chromosome number 21, which produces amyloid precursor protein. As chromosome number 21 increases in Down syndrome, leading to increased amount of A beta 42 protein at the end of the day, thus leading to an earlier onset of Alzheimer's in patients who have chromosome number 21 triploidy, that is Down syndrome patients. So they would face Alzheimer's at about 40 years of age. That's what is written over here, right? That's where Down syndrome patient beyond 40 years of age develop Alzheimer's. Yeah. There are the most common chromosomal anomaly is chromosome number 14 mutations, leading to some Preslin named gene mutations. Yeah, Preslin 1 and Preslin 2. Chromosome 1 causes Preslin 2 mutations, and chromosome 1 encodes for Preslin 1. Chromosome 1 encodes for Preslin 2, and chromosome number 14 encodes for Preslin 1. They both somehow activate, or I don't know, whatever to do to the gamma secretase, leading to its increased function. And chromosome 19 leads to ApoE4. Alright, let's revise this again. Genetics of the Alzheimer's disease, chromosomal mutations, chromosome number 21, chromosome number 14, chromosome number 1, chromosome number 19. Let me revise this again. Chromosome number 21 relating to Down syndrome or something like that. Chromosome number 14, 14, which shows the most common mutation out of all of these, encodes for Preslin 1, and chromosome number 1 encodes for Preslin 2. Both of them somehow lead to alpha. No, it was gamma secretase. Is it even gamma? I don't think it is gamma. Somehow I don't remember the Greek letters, whatever it is. So somehow they lead to increased functioning of the gamma secretase protein, leading to increased amount of A beta 42. And chromosome number 19, which increases ApoE4 gene, leading to increased Alzheimer's risk. Yeah, just I told you just a few minutes ago I told you the most common mutation in early onset familial Alzheimer's disease is chromosome 14 mutation. Now the factors affecting Alzheimer's, there's some things that can increase the risk of Alzheimer's and some things that can decrease its risk. From back of my memory, NSAIDs reduce Alzheimer's disease, and yeah, so NSAIDs use an apostrophe yes. NSAIDs use will decrease its risk. Smoking is also used to decrease risk in Parkinson's and ulcerative colitis. ApoE2 gene. Increased risk is seen in patients who have increased age, 70 years. Familial history is present in them. The female have longer life. ApoE4 gene, aluminum mercury toxicity, head trauma. So Alzheimer's disease more common than Parkinson's disease. In Alzheimer's disease, there is a tau protein and there is alpha synuclein. Alright. So let's revise this. Factors affecting, so there are some factors which increase the risk, some which decrease the risk. Decrease risk is easier to remember. Thus, the things that decrease risk were NSAIDs, smoking, and ApoE4. Alright, the things that increase the risk were ApoE2, age, obviously age. I don't remember what was the age. Familial history was present in patients. Alright, and yes, females with longer life, females because they have longer life span, whatever that is. Aluminum and mercury toxicity. Head trauma, Alzheimer's disease would lead to increased tau protein, and Parkinsonism will lead to synuclein increase. There are other things that can increase the risk of Alzheimer's: decreased folic acid, which is vitamin B9, I remember, increased cholesterol levels, hypercholesterolemia, hypertension, diabetes. A lot of what all the things that my father has: hypertension, diabetes, increased cholesterol level. Yeah, I can remember it like that. Whatever the way best. What is the best way to remember anything? Decreased level of education. Hmm. All right. Whatever that is. So, genetics of Alzheimer's, we have already done that. Factors affecting Alzheimer's. Okay. So, there's an atrophy of the hippocampus, middlemost part of the temporal lobe, which is first affected, followed by a temporal lobe, other parts, and parietal lobe. So, it starts with the hippocampus, followed by temporal lobe, followed by the parietal lobe. Alright. Loss of the hippocampus leads to episodic memory loss. Yeah, as you I remember, memory can be declarative, non-declarative. Declarative memory is further of two types: semantic and episodic. So episodic memory is lost here because episodic memory is stored in the hippocampus and the neocortex, right? Well, the temporal lobe stored the I believe the facts, or the neocortex stored it. We'll have to see it again. We'll see it later on. Alright. And now, parietal lobe, temporal lobe. Clinical features, we can remember this by multiple A's inside its name: atrophy, amnesia, aphasia, apraxia. Well, apraxia is of two types: ideation apraxia and ideomotor apraxia. Atrophy, we have just started what atrophy is. Amnesia, amnesia means to forget. So, and it's of two types: retrograde and anterograde. So, in this, there is anterograde aphasia, amnesia. Aphasia means to aphasia means whenever there's lesion leading to communication, if the person is unable to communicate, I think that's what aphasia is. You'll have to see what it is. Anomic aphasia is seen whenever there is angular gyrus is affected, just as I remember. Right? So, if angular gyrus is affected, comprehension will be normal. Naming, I believe naming shall also be normal. Repetition shall be normal. Well, you'll have to see what anomic aphasia is. Apraxia, ideation apraxia, ideomotor apraxia. So, ideomotor apraxia and ideation apraxia. How do you remember this? Alright, ideomotor apraxia in these, when patient is unable to do individual steps, and ideation apraxia is when the patient is able to perform a directed activity but individual steps required to achieve them Oh, deficit in performing a goal directed activity, but individual steps required can be done normally. So the patient can do normal things, whatever it means. Praxia means the patient cannot do a skillful task, occurs due to parietal lobe lesion, as parietal lobe contains formula cells give input to premotor area and the supplementary motor area. It present in the frontal lobe. All right. Okay, so there are frontal formula cells present inside the parietal lobe, which tell the premotor area how the task shall be performed, what are the things that have to be done in a stepwise manner. Later on, the premotor area controls the supplementary motor area and premotor and the supplementary motor area. Somehow, at the end of the day, through the direct and indirect pathways, control the primary motor area, thus making us do the steps. So at the end, let's forget about it. Apraxia is of two types: ideomotor and ideation. Just to remember it, the idea inside of it should tell us that the person is able to do simple normal small tasks, but at the end of the day is not able to do the bigger goal that has to be done. Deficit in performing a goal, but individual steps required to achieve them can be performed, right? And I don't know how this ends up at the end of the day inside a patient. I just am remembering this somehow. I'll have to ask someone. Ideomotor apraxia and ideation apraxia. Moving on. Agnosia is seen in these patients. This means the patient is unable to identify different things. The agnosia can be of different types, and I'm not going into that. And also, agnosia means the patient is unable to to believe that he has these deficits. Yeah, he's unaware of these deficits. Aspiration pneumonia is the leading cause of death. Decreased acetylcholine in these patients, thus leading to increase caused due to the atrophy of the nucleus or basis of Maynard. Thus explaining us why in treatment we give acetylcholine esterase inhibitors like donepezil, galantamine, and rivastigmine. Right. So let's revise the clinical features. Clinical features. I think there are multiple A's: atrophy, amnesia, apraxia, aphasia. Now, apraxia was of two types: ideation and ideomotor. Ideation was when there was non-achievement of the goals, but simple small steps were being achieved, while ideomotor was that even small steps were not being achieved. All right. There's agnosia. Agnosia was the patient is unable to identify different things. There can be stereognosia, meaning the patient is unable to identify whatever is handed to him. By using his hands, patient is unable to guess what the thing is in his hand. And also agnosia is the patient is unaware of his deficits. Aspiration pneumonia is the leading cause of death, and there is decreased acetylcholine in this patient because of atrophy of the nucleus bacillus of Maynard. Delusion is present in these patients most of the time. False belief that the doctor has been replaced by some enemy known as Capgras syndrome. Alright. Let's revise the clinical features again. Multiple A's, amnesia, which was I believe, what type of amnesia was it? Anterograde. Alright, I've seen it now. Let's revise the clinical features again. Atrophy is of multiple types: amnesia, apraxia, aphasia, which is nominal. Apraxia is of two types: ideation and ideomotor. Agnosia, and the patient is not self-aware of his deficits. What was it called? Anosognosia. Alright. Aspiration pneumonia, increased acetylcholine, and the patient is delusional, leading to Capgras syndrome. Right. On an, I believe this is an MRI. On an MRI, there is an elephant sign. I don't know. The temporal medial temporal lobe is looking like an NFL's trunk. Alright. Whatever the way it is. Treatment of Alzheimer's. Acetylcholinesterase inhibitors shall be given. Donepezil, galantamine, rivastigmine, NMDA. So let's revise the whole topic of Alzheimer's again. First of all, we started Alzheimer's by explaining what happens, what is the pathology. We started with the pathology. There is an amyloid precursor protein which normally is present inside the neuronal cells. Alright, inside the neuronal cells, these neuronal cells, yeah. So where were we? Yeah, we were revising Alzheimer's again. Let's write it. I'll erase it later on. So there is amyloid precursor protein. So amyloid precursor protein present inside the cell membrane of the neuronal cells. It is acted upon by alpha cells or the beta cells. Alpha secretase or the beta secretase produces alpha secretase product and beta secretase product, which is further acted upon by gamma secretase secretase, leading to production of A beta 42 or A beta 40 protein. This is amyloidogenic, thus toxic. So this was the pathogenesis. No, it's not the ending of the pathogenesis. The accumulation of these A beta 42 protein leads to formation of NFTs, neurofibrillary tangles. These NFTs are seen inside the cell. These are seen inside the cell and correlates with the severity of the disease. Alright. Moving on, A beta 42. There's also A beta 40 protein which is non-toxic. That was it. No. Moving on. These Alzheimer's disease patient, these neurofibrillary tangles. Yeah, there was also a tau protein which was required for the stabilization of the microtubules, as the tau proteins in the presence of these NFTs, these tau proteins got phosphorylated, thus leading to destabilization of the microtubules. Alright, leading to neurodegeneration. Also, if the A beta 42 protein somehow affected the cerebral vessels, it was known as what was it called? Come on. Cerebral amyloid angiopathy. Alright. Cerebral amyloid angiopathy. If only the cortex was related to cortical dementia and senile neuro. No, it's not. It was something senile. Yeah. So senile neuritic plaques would be seen outside the cell, and it correlated with the age. Come on. Senile neuritic plaques, which were extracellular and correlated with age. Genetics of Alzheimer's. Uh, there were chromosome number 20. Yeah. Genetics of Alzheimer's. Um, Genetics of Alzheimer's. There was multiple chromosomal anomalies. Chromosome number 21, triploidy Down syndrome, leading to an early onset of Alzheimer's because it produces increased amyloid precursor protein. Chromosome number 14, whose mutation is the most common genetic cause of Alzheimer's disease. Chromosome number 14, uh, Preslin 1 encodes for Preslin 1 gene, leading to somehow activation of the gamma secretase, leading to um, leading to Alzheimer's. Also, there was chromosome 1 and chromosome number 19, I believe. Chromosome number 19 produces ApoE4, increasing the risk. Alright, moving on, there was myeloid ho gaya. Yeah, moving on, we calculated the risk factors which caused Alzheimer's. Some things that increase the risk and some things that decrease the risk of Alzheimer's. The things that decreased were NSAIDs, smoking, NSAIDs, smoking, and one more thing was there. I don't. An ApoE2 gene, right? The things that increase the risk were age was greater than 70, or women, or folic acid deficiency, or hypertension, diabetes mellitus, and increased cholesterol levels. And any more if I remember, it was family history, obviously ApoE4, aluminum and mercury toxicity, head trauma in boxers. Alzheimer's is more common than the Parkinson's disease, hypercystinuria, cystinemia, or decreased level of education somehow. Clinical features: multiples of atrophy. First of all, the atrophy was seen in hippocampus, followed by the temporal lobe, multiple areas, followed by the parietal lobe. Alright, so atrophy, amnesia, which was anterograde, aphasia, which was nominal, apraxia, which was two types, ideation and ideomotor, followed by increased ACH. Remember, one more A was agnosia, and aspiration pneumonia. There is also delusion leading to Capra syndrome. The treatment would be donepezil, rivastigmine, and galantamine. Also, there is an NMDA antagonist, memantine. Okay, the next neurodegenerative disorder is frontotemporal dementia, which is more seen in males than females. The age of onset is less than 65 years. Autosomal dominant and inheritance, which is about 10%. Memory loss is mild and late in onset. Apraxia is absent and acetylcholine normal. Alright, frontotemporal dementia, more common in males than in females. Age of onset less than 65 years. Autosomal dominant inheritance. Memory loss is mild and late in onset. Apraxia is absent. Alright, apraxia was inability to do some actions. Acetylcholine levels would be normal. Chromosome number 9, more common. Chromosome number 17 problems. I'm not going to remember this, I'm sure about that. Alright, variants of frontotemporal dementia. There's a behavioral variant leading to antisocial behavior, which is the most common one. Variant of frontotemporal dementia. There's a semantic variant in which aphasia is seen, similar to Wernicke's aphasia, also known as primary progressive aphasia, dementia, and no weakness. What am I doing with my life? Uh, the different types variants of there are different variants of frontotemporal dementia. They can be semantic variant, they can be a grammatic variant, they can be lopenic variant. Alright, I don't think frontotemporal dementia is that important because I'm not going to remember any of this. There are tauopathies, there are synnucleopathies. Tauopathy, as we have just read about Alzheimer's disease, frontotemporal dementia, Parkinsonism plus disease. No, it was not Parkinsonism plus, it was. What was it? Progressive supranuclear palsy or the Steele-Judson syndrome. So progressive supranuclear palsy. Right, let's revise this one again. Parkinsonism, atypical Parkinsonism, different variants. Progressive supranuclear palsy, in which the patient is unable to see. The place below. Lewy body dementia, corticobascular degeneration, and MSA. Right.